I'm your host, Dr. Risa Ravitz, and I'm not your average neurologist. My interests and passions run deep, and I'm constantly pushing myself to find truths. I'm a medical doctor, a woman, a surfer, a runner, and an exerciser, and an avid reader of all topics. It's not easy to sift through all this information, and there's many podcasts out there. So let's try to get through this together. Hi, everyone. I am very excited for today's episode of the Ravitz Way. We have a special guest today, Dr. Amy West. Welcome to the show.
Thank you.
So I'm just going to preface this with I'm a female, I'm a doctor, I'm an athlete. I'm not as big of an athlete as I used to be, but I think a lot of the stuff that you're doing now is very prescient for females coming up and so forth. So we'll dive right in. Why don't you start by telling us about how you got into this field and what your field is and your training. So it might be a long story. But
yeah. Well, I mean, first I'll say that I'm a physiatrist by training. So a lot of people don't know what that is. So, and I have a subspecialty in sports medicine. So physiatrist, essentially, we're kind of like the best kept secret in medicine, I think. Not a lot of people in medicine know what we are, what we do. But we treat physical manifestations of disease processes on the body, meaning we treat how disease affects you physically and how it affects your function. So, and all kinds of injuries. So whether that's permanent injuries like spinal cord injuries, traumatic brain injuries, or more temporary things like sports injuries, and that's what I focus on. So you can meet two physiatrists who do totally different things from one another, which also makes it more confusing for everyone. But right now I work primarily in sports medicine. I'm a team physician for Hofstra University. I see patients essentially in an orthopedic office. So
all sports?
All sports. And then, I treat, injuries, aches, pains, rheumatoid arthritis, things like that. I do lots of injections, things along those lines. But how I got started in medicine, I was actually, I grew up in New York. I was actually in film school at NYU here. And I thought I was going to work in television. So I was doing that for a few years. Then wasn't really like crazy about the entertainment industry as a whole. So I got a job at Columbia University as a surgical videographer, and I was filming surgeries and making instructional videos out of them.
That's amazing.
For the residents. So yeah, it was kind of
or everything.
In all kinds of things. Actually, mostly like cardiothorac. So back like Dr. Oz before he was like on TV and stuff. Yeah, so I used to like film some of his surgeries and stuff like that. So
that's cool.
So it was fun. And then I was like, maybe I could be on the other side of this, So I went back to school and had to do all like sciences and stuff. I didn't have any of that. And then ultimately I went to med school at Harvard. While I was there, I did an education degree as well. And
so you're smart.
Well, there are days. Smart about certain things anyway. And then actually while I was in med school, there was a lifestyle medicine interest group. And that spoke to me as far as like treating like underlying causes.
What year were you there? Just out of curiosity, because this did not exist when I went to medical school. Yeah. And I finished in 2005.
Yeah, I started in 2000. I started in 2009.
Yeah. Okay. So it's changed.
Yeah, and even then it was like 5 people. It wasn't like this huge group. It was like 5 of us, and the like mentor for the group was a physiatrist, so Dr. Beth Frades, who's actually like was the president of the Lifestyle Medicine Group Association. I don't remember the exact name of it, but. So she, people talking about like nutrition and exercise and things like that, which I'd always been an athlete. I'd been a collegiate athlete. I played professional, semi-professional sports in Europe for a period of time in my life.
Such as?
Softball.
Okay. So
I played in Holland for a while.
Wow.
So I was always like into sports and athletic, but actually like my own health, I didn't really think about that. Until I was in med school. So then I learned about this medicine group, lifestyle medicine interest group, and then I said, I like sports, but like I didn't think I had the endurance to go through surgical training. It didn't appeal to me. So I said, how can I do this without doing that? And that person introduced me to some of the sports medicine physiatrists in Harvard in Spalding, which is the attached rehab center there. And like I just fell in love with the field, as someone into sports, but then also I was there. I did some of my rotations at Spalding right after the Boston Marathon bombings, and there were a bunch of people who came through there, who'd lost limbs, who were kind of like learning how to walk again, learning how to live again, had some traumatic brain injuries, things like that. And the great thing about rehab is everyone gets better, which is really nice, because in other fields of medicine it can be kind of depressing. So it's kind of a nice mix of sort of functional, happy neurology and orthopedics, and non-surgical orthopedics, which spoke to me. So I fell in love with it then. And then plus I like to do procedures, so I like do injections and things like that. So then ultimately did a fellowship after that in sports medicine, and here I am. So right now I'm working, I work for Northwell Health in the orthopedics department.
Okay. What are you primarily seeing? Like what's the majority?
Depends on the day. But so I see sports injuries. So, people twist their ankle, fall down, hurt themselves, anything that's like a non-surgical injury. I see a lot of aches and pains, like my back hurts, my leg hurts, this thing hurts, that thing hurts. I do a lot of injections like arthritis and things like that. I see concussions. That's another part. Mostly sports concussions. Given, and so one of my mentors in residency was actually Ross Affont, who was like one of the premier people in the brain injury field, and works a lot with the NFL concussion study and all that. So got a lot of exposure to that. And then, just like aches, pains, things that hurt people. But then I work with some teams as well. So then I see the athletes from the university who get injured as well.
You love it?
Yeah, there are days I like it more than others, but no, I like it because I think what's most satisfying about it is that when a lot of things that come through an orthopedic office are non-surgical. And
I would say like 90%.
Not most of it.
So I do a lot of pain.
Yeah.
And I've done a lot of pain in the past and work with big groups, and it might be more than 90%, honestly.
Yeah,
and I think people have a thought that the first line is the orthopedist, when in fact it probably should be you.
Yeah, I would agree.
Yeah.
I mean, I think also, surgeons like to operate. That's just kind of what their training is, right? Yeah. So I think a lot of sometimes those non-surgical things get a little bit kind of blown off, or kind of, that's non-surgical, do some PT, go. When there's sometimes it's a little bit more than that to it. So even sometimes just kind of explaining it a little bit better, other than that this isn't a surgical problem, go home, or, it's like said but not said. And then as someone who is an athlete, who's been a lifelong athlete, my goal is to keep people doing the things they like doing. Yeah. And I realize how important it is to people to do those things. So like I am one of those persons who's very rarely going to tell somebody to not do something, or to stop like doing the thing they like doing. It's not that simple to be like, well, if you hurt your knee, don't run. Like that's not acceptable to a lot of people. So then it's like, how do you find ways around it? How do you connect them with people, physical therapists, et cetera, who understand that? So that's the part I really like, is like when you find those people who really want to put in the time and the energy to rehab themselves, and who want to put in the work. I know people who will put you to work and you will get better, but unfortunately it's not the majority of people, but when that's happening,
I think people look for that though. Yeah. I mean, honestly, I did a few months at Rancho in California, and did a fair amount of spinal cord injury and traumatic brain injury and post-stroke and that kind of thing. And I think, what you're saying is it's true. Like most people, they will get better if they have enough time and they put enough effort. And the brain's going to heal, and so is the rest of their body. Yeah. But people don't believe that. So I think it's awesome. It's definitely definitely when you go, not all orthopedists, but just in general, surgeons like to operate, and that's exactly the case. So they will sort of say, well, it's not surgical, and that's it. And then the person will limp around for a year before they, or not do something. So That's great.
Yeah.
I want to read this quote that you put on Instagram because I love this, and I also am going to age myself and put myself back in the dark ages with sports. But
Okay. All right.
so you wrote, "Women are not small men. There are unique physical and hormonal differences for women that affect strength training and conditioning, injury prevention, rehabilitation, and performance optimization." So great statement. And probably is obvious when you kind of think about it, but I don't think the medical community has looked at this like that much at all. So maybe we could break it down a little bit. So
So I mean, first the kind of initial part of that quote, "Women are not small men," that's actually quoted from Dr. Stacy Sims, who's kind of one of the few kind of leading researchers in the women's athletics field, and she's actually been great help to me in helping me get my studies off the ground. So that's something that she always says. But as far as like, looking at these things, so up and as far as I know, the number still stands that roughly 6% of strength and conditioning research is focused on women. So 6%, probably less than that actually. Maybe that's changed in the past year or so since that number's come out. But
and we're not counting like Instagram research, right?
Right, like real research. And then like you're looking at like less than 1% of that are things that are uniquely affect women. So even less of that percentage is things that affect women only.
So give us an example of that.
Well, something like menstrual cycle and athletic performance, for example. That's something that's a uniquely female problem that there's, less than 1% of research is focused on things like that.
Are they doing research on that?
Well, I am. That sort of popped up recently, and like it's been a bit of a hot topic now, like, kind of a thing to talk about. I think this, what we have as far as research in that field around that subject, the data, the quality of it isn't always like the best, or the sample sizes are pretty small. So it's been hard to kind of pin down if and like what the correlations are,
Always
so
hard,
so that's something that I'm actually looking into right now with a study from so I've partnered with a company, Whoop, who makes these bands, and we've distributed them to all the female athletes at Pace University, which is up like in Westchester.
All sports.
All the sports, yeah. So we have roughly like 150 or so athletes enrolled right now. And basically giving them these bands for a year, and they track all kinds of physiological metrics and then subjective emotional data, menstrual cycle tracking, all things like that.
Are they talking to it, or are they?
No, so it connects to an app on your phone, and then you can input things.
Okay.
And it just takes some like sleep data and sleep cycles and things like that. And then we're looking at that data and correlating with the injuries and injury types and injury rates and other things like travel and training schedules and things like that, to see if we can find any correlations throughout the year between, amongst any of those things. So it's a fairly big kind of...
how many people? I was going to say
about 150 or so. And then we got I think we got about 200 bands from Whoop, donated 200 bands to us. So we then gave what we had left to, there are two professional women's soccer teams that are local that we've distributed to them. And then we've pulled in some of the a graduate psychology program, I believe, that's going to be looking at some of the emotional kind of attitudes towards like menstrual cycle training, things like that. And so we're kind of collecting a bunch of data now. We kicked it off in August, and when we're at the end of the year, we're going to kind of pull it all together to see what we can find. So, but one of the biggest studies of its kind, one of the few that I know of. So that's been pretty exciting to get that.
Cool.
Yeah, to get that off the ground and get that going. So that's going to be fun. But it's like a pretty rare thing, like that people are focusing on women's sports and problems that affect female athletes, because until fairly recently, because women's sports traditionally hasn't been something that makes a lot of money. Then it's sort of disregarded as far as like a lot of advancements in training and things like that. We had, when we were distributing the bands to the girls at Pace, we walked into a room that was that like the men's lacrosse team had just been in, and then they left, and we brought all the girls in, and like the room stunk. And we, I said to the girl, I said, like, right now, all the training data that we have, all the things that we're basing the protocols on, are based on those smelly boys that were just in here. Like, you have the power to change this. So, like, let's do that, so, but that's true. Like, we're very true. We're basing all this stuff on, 20-something-year-old guys, which, doesn't apply to everybody.
At all.
Yeah, so.
To at least 50%, right?
Yeah, so, yeah.
So is there any general advice or guidelines for, like, girls growing up and training and what they should do and what's, like, I know it's probably not...
Yeah, I mean, so one of the things that's kind of unique about girls in sports, as compared to boys, is that when, at puberty, so when boys hit puberty, their athletic performance usually skyrockets. Yeah. They get bigger, stronger, faster. Whereas women often have a bit of a dip in their athletic performance. So, things that they were usually do more easily become a little harder. They have extra weight, dealing with menstrual cycle, things like that. And then also, at a certain point, boys and girls can kind of play together somewhat equally, and then there's sort of like this turn. So one of the big things is that sort of navigating that dip. What does that look like? Just emotionally kind of sort of maintaining this, that some kind of training in a young girl's life, and in that retention beyond that period is important, because it's sometimes people don't really like understand that difference.
It's a big difference. I mean, it's basically like you're telling me that men are already pretty good and more apt to be stronger, faster,
right?
And then they get more tools to do that. And then for women, it's kind of the opposite. So,
it's also encouraging, when you're like, see this steady improvement. Yes. Whereas girls don't necessarily see that. So that's a big thing. But then also, I mean, one thing that I see as far as like what I see in a lot of young girls especially is the strength piece is absent. Or it's like diminished.
Totally absent.
Yeah, from their training. And even when I played college, I played beyond that, and like our like weight training was like everyone just kind of like sit around, and like no one really paid attention to it. I mean, I'm sure things have changed now.
I'll tell you my story too about that too. It's kind of pathetic.
So like we didn't really focus on it, and it's a huge part not just for sports but for stability.
Yes.
As you get older, injury prevention, and there are certain injury patterns that we see that are very classic kind of things that girls get because of the way that we're built. But also the lack of strength, and also the sort of the mechanics of our body. The way girls jump and land tends to be different than the way boys do, which predisposes them to certain kinds of knee injuries, for example. The way, so when someone says like throw like a boy, there's something to that, right? How you move, the sort of functional movement patterns that girls exhibit versus boys. There's a way to kind of to level that, which I think, especially in girls, it's tends to be overlooked or kind of minimized until we see like ACL injuries and things like that as they get older, and everyone's like, oh, actually, let's go, fix these things. And it's like by that point, we're already kind of down a different road. So.
Okay. So so I'll tell you my experience basically. So I played a bunch of sports in high school, then played field hockey and got into college, I think, because of that. Well, some other stuff. But when I got to college, it was Division III. And the coach was definitely ahead of her time. Like, she put us on these crazy strength training, like regiments, and like tons of calories, like 3,000 calories a day. And a lot of that, I got scared and was like, oh, I can't do that.
Yeah.
But what I see happen is like I was injured most of those seasons, with different things, knee, groin, like all the sort of obvious things. And the people that stuck to it, they got way stronger, way faster, like much more stable. I mean, they gained weight, so I think that that's part of maybe like in people's head as well. But yeah, I think there's something really to it. So has it changed? Has like high school sort of changed that?
I do think, I mean, I think sort of a cultural thing, but I think there is more of an emphasis on what a woman's body can do rather than what it looks like. You know, I think there is the appreciation of strength and speed and things like that, you know, with women's sports being a little more in the public eye, and it's not just about, you know, how skinny you are. So I think that's changed a little bit.
So would you tell people like in high school to lift heavy? Like women?
Yeah. I mean, it's all relatively heavy, right? But so lifting heavy for sure, but also working on proper movement patterns is a big one.
With lifting or just in general?
Yeah, with lifting and in general. So like things like squatting, like how to squat properly, actually super important. Being able to activate your glutes, that your knees don't cave in when you're jumping and landing or when you're trying to turn. Super important.
That's easy. I mean, to teach, like, I didn't learn it. Yeah.
So something like that is actually super important. So, you know, working on stuff like that. And then also on the other end of it too is adequately fueling your body for competition, because I think that's something that people get hung up on. Another thing that I see quite a bit of, and especially in certain sports, it was traditionally known as a female athlete triad, but now has sort of different names, relative energy deficiency, because we see it in men as well. But it's this triad of, you know, you're basically not eating enough. And then as a result of that, you get some hormonal derangements, often presenting as loss of menstrual cycle. And then ultimately your bones are affected, and that's when we start seeing stress fractures. So, and then, you know, as an orthopedist, you see the stress fracture and you want to treat the fracture, but if you don't explore those other things, like you're missing a whole problem. That person will continue to have these injuries over and over again. And especially in young girls, because you reach your peak bone mass by the time you're like 18. Yeah. So like if someone's a 14-year-old having stress fractures, like this is a big red flag, because it could potentially set you up for like a lifetime of, you know, reduced bone density, which is a big problem. So, what
sports are you seeing that with men?
So I see a lot. I've seen
wrestling, maybe
cross country. Yeah. So, because it's a lot of, you know, high volume running. Yeah. They're very, you know, tend to be on the skinnier side, so they're just not eating as much, training a lot of high impact in one plane of motion. So yeah, I've seen it more often. The cross country guys are the ones that I see it in the most in now. But, you know, guys being treated for, like, quad strains that never get better. And it's like, let's look at their bone. If their bone is just a big swollen, you know, problem. So, yeah. It gets missed in men quite a bit, too.
Okay. So just to give some good advice, because I think this is awesome. Like, so cardio versus weights versus both versus what's a good... And is there any age changes where, because that's where people are looking a lot, and I know there's a lot of advice everywhere, but not that helpful.
Well, I'm trying to remember the quote exactly. So it's that cardio adds years to your life, and strength adds life to your years.
Yes.
So it's a little bit of both, right? Yeah. You can't do all one and all the other, and I think that's the problem. Especially I see this in runners, for example. So. Running especially is great, but it's all kind of one plane of motion, right? It's all this way. And I see what happens a lot is that as a result, people get like knee pain, they get hip pain. And part of the reason that's happening is because their glutes, which control side to side motion, but they also stabilize your hips and your knees and your back. When those are weak, which a lot of runners tend to be very quad dominant, not glute dominant, their whole body kind of caves in when they're running, not realizing it. And then over time you add that, you know, over thousands of steps, and they get pain. And part of it's like they're not building up the strength around their hips, essentially. So there has to be some element of cross training to people, even if they are mostly runners. I mean, I see this with older people as well. It's like, especially older ladies who are like, oh, I ride my Peloton every day or whatever. And it's like, that's great, but you got to get off of it at some point. and do something else.
Yeah.
Because the cardio is great, and it's better than nothing. It's better than sitting down and do nothing. But you're not necessarily getting stronger doing that.
Yeah.
So you're not loading your bones in the same way. So I think the lifting heavy actually is more important as you age.
Interesting.
Because
and it's harder then.
Yeah, right. So
yeah.
But as you have increased risk of osteoporosis and things like that, you have to be loading those bones. But obviously, the earlier you start, the easier it is. So, but it's never too late, right? So you can always get stronger, which is good. That's a good point, right? So, so there's definitely like, everyone should be doing it. And like what heavy is to me is different. It just has to be challenging. That's okay. The gym should be challenging.
Yeah.
You should sweat a bit. You should feel like you're moving with some intensity at times. Like, I think that's also another thing where like it's not just like a cosmetic thing. I think you got to sort of get out of that mind frame of like you're doing this to like fit into a pair of pants. Like, it's really just to kind of keep you living well. Yeah. So.
Some of the people I work with, the goals that they try to do is like, be able to lift the luggage and put it into the overhead bin, or
that's a very
lift up
movement.
your niece, or like it's real, because that's where everyone gets back pain, neck pain.
I mean, that's kind of where I try to focus a lot of the conversations is like, what are you doing, or what are you not doing that you want to do, or what are you doing now that you want to keep doing? And I mean, the airport's a great example of like just
a trial.
Yeah, you like need to in order to travel and to travel without pain. Without pain, travel well. You have to navigate places quickly. You have to lift things. You got to put them overhead. You got to bend down. I went on a tour of Italy with my mother, and I was in a group of probably like 25 people over the age of 65 and me. But the range of people all roughly the same age, and how functional some of those people were. Could they navigate cobblestones? Could they get up a flight of stairs? Did they have to sit out of things that didn't have elevators? Were they exhausted by the end of the day? Were they, and it really, how much you were able to enjoy a trip like that is really based on how functionally, how your functional upkeep is of your body. Yeah. So super important. And that's a practical measure of that.
Yeah. I'd love to dive into a little bit of the specifics. Like maybe, so knees in women. Tell us. Yeah.
Well, so with knees in women, there's a few things. So there's, one of the major differences, male and female hips, is something called our Q angle. So essentially it's the angle at which our hips and knees kind of go inward. And women have a larger Q angle, so we're kind of more V-shaped, whereas men are more straight. So this sets up the mechanics of the knee such that contributes to things like ACL injuries, but also contributes to things like it's called patellofemoral pain. So I see a lot of that. It's like this sort of vague knee pain behind the kneecap that women get. A lot with you get a lot with running. You get a lot with prolonged sitting. And essentially what happens is because of how legs are shaped, some people are more prone to it, but also the strength around the hips. What happens is when someone stands on one leg, for example, and they do like a single leg squat on that side, that's like one of my favorite tests to do for people. You see where the knee tracks, and a lot of times women kind of cave in as they bend. Yeah. And that's because the glutes aren't holding or aren't preventing the knee from tracking in. So as a result, you have essentially leg bone going in this way, kneecap that sits on top of the leg bone kind of tracking out that way, and you have these two things that are at an angle, and then they sort of, every time you flex and extend your knee, they're kind of scraping on each other, and you get this pain around the knee. So single leg squatting or single leg standing is that's a test for like everybody to do. So it's like, can you stand on one leg without falling over is like case number one, and you'd be surprised how many people cannot do that. No,
trust me, I do it. I do it in my practice too.
So like a lot of people just can't do that, and they say it's my balance. It's not your balance. Because unless you've had a stroke or something, it's not your balance. Your balance is fine. You're not. It's your stability. So so that is test number one, and then I see, can you bend that knee? Can you squat, or at least halfway down? And what does it look like? And most people are like all over the place, and that knee's caving in. So then they have knee pain, they have hip pain, they have back pain. It's a fairly common thing that I see. So, as far as like non-surgical things go, that's like number one. As far as like the main difference I see with men and women, men can usually stabilize that a little better, but they get it too. So that's really like the main thing. And the same thing is like the jumping and landing. That's why we see a lot of non-contact injuries and ACL injuries in like basketball, soccer for women, is because a lot of this kind of, they jump, land, and they land and their knee just kind of catches it at a bad angle, and there it goes. So, plus our ACLs are just physically smaller and sort of things.
They're more lax, you think?
So there are some like hormonal differences so estrogen tends to make ligaments tend a little more lax. There's some evidence that like right around ovulation, there's a little kind of boost in estrogen that promotes this laxity. So they're seeing potentially, a thought is that women are more likely to tear their ACLs during at that time of the month.
It's gonna be interesting with your study.
Yeah.
Wow.
Yeah, and even if we find that, then it's like, what is the reason for it, right? Is it because there's this laxity in the ligament? Is it because recovery is affected later in the menstrual cycle, which sets you up for an injury in the mid next cycle? There's a lot of like.
Wait, recovery is later?
So basically so in the latter half of the menstrual cycle, kind of when progesterone is dominant, the idea, some of the evidence shows that women are less able to recover. So things like deep sleep are affected, and like stress on the body is less, like things like HRV are lower, like heart rate lower. That's what's a lot of the evidence shows during that half of the cycle. So then they're saying, well, if you're not adjusting your training for the latter half of the cycle such that your recovery isn't as good as it could be, then maybe when you start the next cycle, you're more prone to having an injury. Maybe, again, we don't know. And there's a lot of sort of people looking into this and drawing conclusions, and then others saying, that's nothing, that's not real. So there's like, so I can't say anything's definite, but there's just some trends we see and sort of putting something to that. So there's some laxity. And then beyond that, you have, so like that's why in men, and their tendons tend to be a little stiffer, a little stronger, but they're a little stiffer. So things like Achilles ruptures, you see more often in men. And then after like menopause, those rates kind of even out. It's like there's positive negatives.
Tears too, same.
Similar? Do see more of that? Yep. In men, right? Yeah. And then there's different. So we do see there's some like trends there. There's no like absolutes, but that's kind of like see more of that and less of this. The interaction between hormones and the musculoskeletal system is something I've always been interested in. So that's part of kind of what we're looking into.
I mean, I'm interested too from a brain perspective, but we are like, we don't know. Yeah. It's pretty hard. It's definitely pretty, it's complex. It's very complex. So I think that's. And
then on top of that, you add in something like, oral contraceptives, which are like all over the place and especially in like the collegiate female athlete population. And like, how does that affect everything? Because, that's
basically on hormone. Yeah.
Yeah. So you're basically on hormonal therapy that like lowers all of the fluctuations throughout the menstrual cycle. It just makes you kind of, even. Essentially it's chemical castration when you think about it. So, so how does that affect anything, or does it not affect, or is it protective? I don't know. So that's another thing we're looking at, because I think if there's something that we found, for example, that something like that was protective from an ACL injury, then every athlete I know would be like,
definitely
give it to me, right?
Yeah, definitely.
So, and does that affect things like, because we're also looking at concussions in this too, so.
I definitely want to talk about that.
Yeah, so
and
it's
we'll
like.
talk about women, neck, and concussions.
So. Definitely.
Big theory, obviously, that women in soccer in particular, I guess those numbers were a lot higher, thinking that the head ball was somehow destabilizing muscles here, and the concussions were much worse than in men, right?
Yeah, so that's actually, other than like contact football, women's soccer has the highest rate of concussions. So, that's something. Neck strength is certainly something that in general, women don't train their necks. You know, it's not something.
So you think the load is just going right through the brain instead of like.
Yeah, there's no stability there.
Yeah,
you know, there's no like stability. So like in concussion, you know, as you know, a lot of it's like the torque on the head.
Yeah.
So if you're not stable in that position, that can certainly contribute to that. And then there's been some studies that like women are less likely to like report having concussive symptoms after.
I think
So it's like, that's, again, it's like some studies show they're more likely, some less likely, or more likely to have some of the, if you look at like the concussion symptoms, it's like some of these pre-existing things already, like women are more likely to have some of those things at baseline. So then, you have a concussion, it complicates that even further. So
concussions in females. Yeah. So I remember playing soccer as a kid and having to do the head ball. And I remember one hit me and I felt so dazed. And I was like, I don't like this. I don't like this. And then like the coach would line you up and throw the ball at your head again and be like, do it again. And I remember being scared of it actually. And then like if there was a punt or something big, I would not head that thing. But I don't know. We have a professional soccer player here, and I feel like I don't know, maybe it's easier for the men. I don't get it.
There's I think the neck strength certainly has something to do with it, and then there's techniques. Is that drilled the same? I don't know. Certain people are, so there's been a lot of talk about those like bands, whether it's like concussion bands and
I'm not so sure.
So they've what some studies have found, it just makes you more likely to put your head in a place it shouldn't be. So I do see that sometimes. I see certain kids that like have had multiple concussions. I'm like, you're someone who just puts their head in a place it shouldn't be in, and that needs to be addressed. You're not something
maybe
here is
maybe that's a post-concussive symptom of
potentially
just,
it's like
not making good executive decisions at all after, right?
So so there's a lot of theories about it. I think also like women's sports have changed, right? So what was considered, I think women's like soccer, for example, or like basketball, even like in a 20, 30-year time period, the game's gotten much more aggressive and much more like it's just different. And the amount that girls are training from a young age for in like sports specificity is gone up, and things like that. So, which in itself has its own risks. So there's just like the landscape is a little different too than what it was.
You have any thoughts on equipment, like helmets versus? Well, so the helmet thing I wanted to ask you about is basically. Actually, I don't know if I'll get into this. Basically, I went to a conference and they had put sensors in helmets, basically in football helmets. They didn't tell us which company, and they kept like, the sensors going, and then they didn't publish the data. There was like thousands of micro traumas, like in a season of, it was high school football they were looking at. So. Do you think equipment sometimes will put people in a place that they shouldn't be? So like women's lacrosse wearing the full like face shields now. When we played, women didn't wear it. So we were careful. We had obviously people got hit, but it wasn't the same.
Yeah, I think it's a little bit, some of that stuff provides a false sense of security. So then, brings down the threshold to do things a little bit.
Yeah.
Some of that, I think when we talk about like helmets or like face shields and stuff, it's like know what they're really good for, and preventing yourself from getting your teeth knocked out or from getting your eye poked out. Like that's what it's good for. Like helmets are good from like skull fractures. Like that's what it's good for. But to say that these things are preventing concussion, again, because sometimes it's not even. It's not the actual hit, but it's the torque that it causes that is really the issue. So, again, it's a lot of just like false security. It's better to have those things than not have them, but sometimes making like little tweaks to certain things and then calling it like, now this is going to prevent your concussion, doubtful. Yeah.
What do you think about shoulder injuries in women? So the women in their, so what's the saying again? Women in their 40s, female shoulder trauma. They had like this frozen shoulder thing.
Oh, frozen shoulder. Ah, okay. So frozen shoulder, that's kind of an interesting thing because often it is a sign of metabolic derangement. I found.
Oh, really?
Metabolic derangement or hormonal derangement.
Really?
Yeah. So, in the absence of a trauma, of something that happens to your shoulder, so developing a frozen shoulder essentially is like the joint gets all like inflamed and stiff, and a lot of times that's associated heavily with diabetes.
Huh.
But not just diabetes, but pre-diabetes. So and this
Did not know that at all.
Yeah, so a lot of my another kind of thing that I'm into talking about is the effects of metabolic health on the musculoskeletal system, because I think there's a lot of that kind of gets ignored a little bit.
Totally ignored. How many times has someone gone in with a frozen shoulder and just got a cortisone shot and nothing checked? Nothing.
Right. And a lot of those times, I mean, I've seen this a lot with like chronic tendinopathies, arthritis that is sort of out of pain, that's out of proportion to the pathology, frozen shoulders for sure. Trigger fingers is another one that's fairly common. Flexor tenosynovitis is like often a harbinger of metabolic dysfunction. So, something that I've started doing is...
You're saying like pre-diabetes and sort of just it's like, syndrome X, just...
Yeah, it sort of presents as a musculoskeletal complaint because and like physiatrists or sports medicine people are often the first line of that, because people don't go to the doctor and say my A1C feels off, right?
No.
They say like,
no.
my finger's stuck, you know what I mean? Like, and that's going to drive them into the office before anything else, right? So it's like, okay, we see, more often than not, especially like trigger fingers, it's just like you see that on somebody who's like, have you had your A1C checked? Have you?
I had not. I wouldn't even think of that ever, but now I'm going to.
It's a pattern that I've seen, or like, and adhesive capsulitis is another one that I see a lot. That it's usually
frozen shoulder.
So like, you look at for example, like, this like idea of like whatever the saying is, like 40, whatever. And it's like, what also happens at that age, right? It's like the wheels start coming off if you haven't been taking care of certain things, right? Like, and that's when it starts showing up, is like these musculoskeletal issues a lot of times. There are some things with like estrogen changes and stuff like that can also affect the musculoskeletal system, but they kind of create the perfect storm of like, your body is like in a soup of like
inflammation.
Yeah. So it affects your everything's you have pro-inflammatory cycles, your cartilage, like your chondrocytes, all the cells that help in recovery and repair are damaged, and it's like this cycle. You're sitting in this like soup of inflammation. So that also things, because how I sort of came to this, or how kind of what kept hitting me over the head, was that I would see two patients who, like, I talk about this one person in particular, because I see a lot of like CrossFit athletes, and because that's what I do, so I see a lot of people locally who own gyms or personal trainers, whatever. And I had this lady who came in who was like in her 60s. She owned a gym. She was like jacked, and she was like, my shoulder's bothering me. I can't like do as many pull-ups as I used to do, And then a guy down the hall, sort of similar age, was like, my shoulder's killing me. I can't do anything. And I x-rayed both of them, and his x-ray was kind of like, meh. And her x-ray was like one of the worst shoulders I've ever seen, like horrible arthritis, like big osteophytes, like. And I was like, I don't know how you're moving your arm. Forget about like doing pull-ups with it, right? And it like. So I was like, well, what's the difference here? Like, what, this woman who's like active, she's metabolically healthy, she's very strong, and she has this horrible pathology that's like bothering her a little bit. Meanwhile, this guy down the hall is like, just nice, like your average kind of dude is like, he's not sleeping that well, he doesn't eat that well, he's on a ton of medications for all this other stuff, and it's just like, what's the difference here? So And I see it time and time again, especially with like older people who like.
I see a lot of older people too with that too. It never crossed my mind to do that.
Yeah, so I see a lot of like, I'll see like, I have another guy who's like in his 80s and he's a swimmer. He loves swimming. And his shoulders are like destroyed. He's got no cartilage in his shoulders, but he's still swimming though.
Yeah.
I mean, and he loves doing it. And like someone with a shoulder that was half as bad would be like incapacitated. And you go, oh, okay, what's the common denominator? What's the difference here? So
interesting.
Yeah.
Any other like pearls like that about like what to check for? Because that's, I mean it's like, I see neuropathy, so obviously I'm checking that. But now that I'm thinking about it, like, why wouldn't it affect the muscles and tendons? I mean, if it affects nerves, like it's the same kind of pathology.
Same thing. Yeah. So like A1Cs for sure, kind of the first thing, like looking at, sort of, or even like, well, I'm a big fan of DEXA scans.
For everyone or just for females?
For lots
everyone?
of people. So, I mean, I think they're sort of like the traditional DEXA scans that look at bone density, but then there's also like other DEXA scans that look at like body fat percentage.
Okay.
And things like, I think that's super important, like central adiposity and like, looking at like body fat percentage and muscle mass. Super important to get measures on those, like objective measures on those, because a weight is not going to tell you very much.
Yeah.
And I think it's also a bit of an eye-opener for people when they see it. I'm like an in-body scan, if you ever even know what those are kind of like, they're like no radiation. It's kind of like a fancy scale you stand on and you hold the things and it gives you like a printout. Love those. If I could get one of those for my clinic, I'd put everyone on it. Like, you know what I mean? Like,
yeah.
Northwell, listen up, buy one. But, so I think
I've seen those.
Yeah, that's like, those are great. And it's like eye-opening information for people. Because people like, oh yeah.
So they see like their weight hasn't changed, or they're still fitting in the same clothes, and they're like, I've this is my high school weight or whatever, but then overweight, elevated A1C, can't move very well.
Yeah. So I think those are super useful to kind of, it's a bit of a wake up call for people. And then, and I find like a lot of these things when they present in the musculoskeletal system are often at a point where you can still kind of wrangle it. Yeah. By the time it's like gotten to your nerves, like, it's a lot more difficult,
There's not much. By the time it gets to the nerves, yes. And that there isn't much. There's IVIG, which is like off label and doesn't, Yeah, I've also seen a lot of gout cases that come through my office, but that come through my office as a, it's a referral for a swollen joint, right? And these are often people who've been in the emergency room. Atraumatic, ankle swelling, foot swelling, whatever. And like somehow the ER convinces them that they must have hurt themselves. It's like, oh, did you fall? Like you must have, and the person goes, I think I twisted it at some point. And they come in, it's like, I go, you would know if this happened. But again, like aspirate that joint, send that fluid off. It's like super inflammatory. Like it, slam dunk, but it gets missed. You're doing that too? You're doing a lot of joint diagnostics as well?
Oh, a ton. Yeah.
Oh, wow.
Yeah, so I do a lot of like aspirations, injections. It's a lot of what I do. But yeah, it's like I see that get missed all the time I've seen people who have had surgery on joints that were just raging inflammatory problems. Wow. But again, that's like another huge red flag. And that's something you see a lot in younger people.
Really? Like what age?
30s, 40s. I mean, I'm seeing gout cases, and
you think it's from that and diet? I mean, obviously.
Well, yeah. So they affect each other, right?
Yeah. So not.
Yeah, like these pro-inflammatory diets, which set you up for a metabolic mess later.
How much? I don't know how we're doing on time, but how much did you? We're good. So, in my medical school training, we had zero nutrition training, like zero classes, like actually zero. And I think maybe that we had one class about, no, we didn't, because I remember I had to consult like, nutrition basically in the ICU to see how to replace, things through the vein.
Right.
So what are your thoughts, maybe just general thoughts about nutrition? I know it's a tough one and it's very controversial.
Yeah, so everyone's got their opinions about it.
Yeah.
I'll say this. Be careful where you get your guidelines from. Meaning, we didn't have a lot of nutrition training. That being said, if we did, it probably would have been heavily influenced by the people who make the rules about it.
Yes, for sure.
And who are those people? Often, you know, let's not talk about it now actually, but like big food, big pharma,
Yeah.
you know, they are funding the science that makes the regulations.
Yes.
Which then make the education. Right. So you go, well, I don't want that kind of education.
Yeah.
Right. And the same goes for your exercise guidelines as well.
Yes. Well, it's cottage industry pop-ups that are popular, and that's what's the attention goes to. So the money goes there, and I agree with that completely.
So I mean, as far as your exercise guidelines, the biggest funder of the Exercise Medicine campaign is actually it's a Coca-Cola campaign.
What?
Yep. So
Is it?
Yeah. So look it up.
What does it say?
So
drink
basically,
Coca-Cola, exercise and then have a drink of
well,
Coca-Cola.
what they say is they say that you're not overweight because you drink our product. You're overweight because you don't exercise enough. Here's how you do it. And if you want exercise guidance, the people telling you the exercise guidance should not be talking about your nutrition because they're not qualified to do it.
Yeah.
So that's their stance, right? And so the ACSM, which is the American College of Sports Medicine, one of their biggest donators, one of the biggest funders is Coca-Cola, which now has transitioned to being called the Gatorade Sports Science Institute. Which
nice pivot.
Yeah.
Nice
so
pivot. Okay.
they're and they fly that flag high at the conference, but they make your exercise guidelines. So
they're the ones that. Okay.
Yeah. So
it's like your committee doesn't, and the American Academy of Cardiology doesn't, and
well there's all different guidelines, but
yeah.
like the ACSM has sort of like the exercise medicine campaign is like they're kind of big. Their big thing, and it's like at the surface you go, yeah, exercise is medicine, great, I love that.
Yeah,
sounds great, I love that.
But do they have guidelines like specific?
Yeah, and a lot of like the CDC guidelines and all that, they're all kind of funneled through the same channels, right? So, and then they have science that proves that they're right because who's funding the science, right? So it's like if this used to be all kind of like conspiracy theory stuff, and we in the CrossFit community used to talk about this stuff quite a bit because they came for CrossFit.
They did.
Yeah. Oh, yeah. So there was a big. You open a can of worms now, but so basically,
tell.
This was like 10 years ago. So when CrossFit was kind of new on the scene, they were very vocal. In the founder who was running the company at the time, Greg Glassman, he was very vocal about this calling out this connection between Coca-Cola and exercise. And they didn't like that. So they basically started publishing a lot of anti-CrossFit research, saying it's dangerous, saying it hurts people, and trying to actually pass legislation that CrossFit couldn't exist without certification through the ACSM. That basically they were endangering people by not having their certification. So because there's a big sort of monopoly on exercise practitioners.
In general,
and stuff. So there was this kind of thing where they were going after CrossFit gyms and CrossFit as a whole, publishing a bunch of false data, which actually was a very big case that was settled recently out of court, where they were found to basically publish false data. It was they had to retract and pay to
the damage is done.
Yeah, but right, it was like 10 years later, right?
Yeah.
So it's all kind of a very interesting story, and that's kind of what drew me into. I started CrossFit, started looking into that stuff, and I was like, wow, this goes deep. And now it's kind of funny because now it's sort of like more in the public eye, people talking about like these influences in food and exercise guidelines. But yeah, so that happened. So going back to your original question, did we get a lot of education? No. Would we have gotten good education about it? No. So so I tend to. I understand the call for it, and there's been a lot of that recently of saying doctors don't get any education in nutrition. It's like, yeah, but who's going to provide the education? That's the bigger problem, right? So,
no, it's totally true because it's probably been a journey for you. It's been a journey for me, like nutrition, right? It's a constant journey. That's I don't have answers.
Yeah.
I mean, I have basic ones, but not like anything super clear.
I mean, for me, I try to advise people to really prioritize protein. So you're looking like a gram per kilo of ideal body weight a day. So it's like 150 for your average person, 150 grams a day. And if you can just do that,
probably good.
You're going to be ahead of most people. And also it's really hard. I think people I tell people just track everything you're eating for a week. and just so you can kind of see it and look at like the macros in there and see like what are you actually eating, because I think it will surprise you and you'll be surprised how short you are on the protein goal, usually very short.
Yeah. No, I found that. And I think patients find that too.
Yeah.
That's good stuff. You're doing very cool stuff.
I'm trying.
Yeah. It's just like from the neurology perspective too, it's, how do we treat a brain? What's good for a brain too? It's exercise and movement, right? So, and also moving through these things. So like people are always asking me, will I get better? Will this get better? Will this change? Will I learn more? Basically, from the neurology perspective, so something simple like stroke or TBI, so traumatic brain injury, it takes a long time for that to heal, and then to make new connections and relearn how to potentially do, first of all, the connections, but also how to do things, how to do activities of daily living, how to build. And I think with movement, it's like a little bit of a like less intense kind of experience, right, than if you had like a brain injury. But when you put it all together, like people need to move, like they need to do it for their brain. And then what happens is, just like what you see all day and what I see all day, is that they get an injury and then they stop moving, and then it continues, and then they eat more, and then they're sitting more, and it's just
cycle. It's
a cycle that's just, we talk about a lot, and it's talked about on, in every venue, but it's very real. So I appreciate what you do, because I think, I've been through injuries, probably you've been through injuries too. You feel laid out, you feel like it's never going to be the same, you feel kind of downtrodden about it, but the body will heal, and at all ages, right? It's like maybe it'll be a little harder like every 10 years as you kind of move, but it will heal. So I love it. It's
better to, so I tell people it's better to be moving than not moving.
Yeah.
And then also, as far as like, with the injury, someone's dealing with an injury, whatever it is, it's like, okay, let's try to focus on what you can do. What can you do?
Yeah.
Let's do that. So like I try to, because it's easy to say, well, this out, I can't do this, I can't do that. It's okay, well, what do we have here? What can we work with? So that's kind of important to kind of keep that in people's mind. And
I love that you don't tell people to not do something. That's...
Oh, never.
I mean,
very
it's
rare.
Also, it's the same. I feel the same way. And a lot of people come in after lifting injuries, and they feel like their neck, they can't do it, but that's the only thing that gives them some, not joy, but just sort of the adrenaline rush that they're looking for. And
I mean, also a lot of times too, it's like some of those things, it's like if you do it the wrong way, it will hurt you. And if you do it the right way, it will rehab you.
Yeah.
So then it's figuring out, okay, well, you did something here. Like, let's figure out how to do it. Like, don't stop doing it, just do it better.
Yeah.
That's usually the road I try to take if I can.
Yeah.
Yeah.
Well, it's awesome. Thank you so much for coming.
Thank you.
Where can people find you?
Best way, so on social media, it's at Amy West MD. It's kind of the easiest way. I do see patients in New York at Northwell Health. I'm in the Department of Orthopedics, but I'm a physiatrist, but I'm not in the physiatry department, so that confuses everybody.
So you're getting a pretty good test just to find you?
Yeah, sometimes a little challenging. And then I do some like online kind of education stuff through Best in Class MD, which is like a like basically education kind of stuff.
So it's like paid courses or free courses?
So it's basically like patients have like specific like questions, like say they've seen somebody and they've gotten some recommendations and they want to just like see what I think about it or see what I...
so it's like a second opinion? Or?
Kind of, yeah.
That's cool.
Yeah,
that's
so
really
provide
cool.
some education about some things. So I do that.
So you're Northwell too, or...?
No,
that's your own
it's like a separate company. So it's like not like medical treatment because I can't do that. But I could educate you about something.
I see.
So there's that. And then got my website in the works, should be up soon. amywestmd.com. I'm working on a book. Hopefully that'll be out next. Hopefully in the next.
That's amazing.
Hopefully,
that's amazing.
Hopefully that'll be on.
What's that going to be?
Basically about kind of stuff we're talking about as far as like metabolic health and musculoskeletal health, and sort of the reframing of like there's orthopedics, but really unless it's like traumatic, it's mostly musculoskeletal health, which is really the idea. So looking at that,
it's amazing.
So I'm doing stuff. I'm always somewhere doing something, talking to somebody. So.
And favorite sport is?
I'm a CrossFitter primarily.
Okay.
Right, CrossFit, Olympic weightlifting. Those are my two things. I just came back from the American Open finals, so that was fun.
How'd it go?
Came in second. So.
You came in second?
I did, yeah, in my age and weight category, but yeah.
You're stronger than I am.
So, it's good. So
Much.
doing some competing in the CrossFit next month. So yeah.
What's your event? Excuse my ignorance on me saying that, but there's specific lifts, right?
In Olympic weightlifting?
Yeah.
So it's snatch and clean and jerk are the two lifts that you do there.
Okay. See,
and then and then CrossFit's a little bit of everything, which I like, so I do that too.
Amazing. Yeah. Amazing.
Cool.
Thank you so much.
Thank you. Yeah.